And so I'm very pleased that Kaveri is able to join us. She's a postgraduate at Southampton, but a lot of her work has been in India and been looking at this issue of obstetric violence. Now, Kaveri, can you start off just by describing the kind of work that you've done and some of the projects you've worked with in India, and then the focus of your research and how you frame this term obstetric violence. So over to you.
Thank you, Neil. So I started working on obstetric violence, and when I say working, it's not all formal, because I did my nursing and midwifery pre-service education in India in government sector at one of the biggest tertiary level hospitals. And I observed the issue firsthand. And there was no terminology that was going around, not at least where we were studying. Like there's nothing about obstetric violence or respectful maternity care when I was doing my nursing and midwifery. And this is 2004 to 2008. And we do these courses quite at a very young age. And seeing women experience violence like that, when you're still finding out how people give birth, and it's quite traumatic in itself, and nothing prepares you really to observe women getting violated like that. And something that looked very normalized, like nobody would look back and suddenly if a care provider is slapping a woman giving birth when she's screaming or she's moving her leg. And in my country, in the government sector, women usually give birth on something called a labor table. It's like very high and very narrow. There's like no scientific basis of why women have to give birth on those. But what I have heard in my doctoral research is that it's good height maintenance for say doctors and care providers, for whom it's like elbow level. You don't have to bend too much, so that women are at that level when you're assisting births. So I saw that, and I also kind of felt a lot of powerlessness in trying to stand up for women. I mean, I was a student midwife, but just these really extreme cases would stand out, when you would be like, how are you not doing anything? Why would you slap somebody? Why would you pinch somebody with an artery forceps she's giving birth? Those were obviously, you see and that's not right, that's abuse. But there were other things as well about episiotomy, about not giving a cut to every woman who's a primary and there for the first time. So trying to address that at that age kind of had its own repercussions on me. And then after I completed, and I felt that, well, why are doctors and why are people who have a say and are making some are being heard? There's a difference. They have qualification, and so this was quite silly, not being able to make a change at that level, that I decided, when I finish this, at some point I'm going to do a PhD on obstetric violence, because then nobody will be able to do away or ignore my voice, because I will be speaking with research, with science backing what I'm trying to say. And it's been around 13 years since. Around 10 years later, I was able to start my PhD here at Southampton. But there are better reasons. I had done quite a bit of research in between as well, and most of my work is in India before I started my PhD. And now I look at the evidence around the world, and to talk to you about obstetric violence, there's so much that we weren't even thinking about, deciding for these women and these people who give birth, and sometimes just being their guardians, like their surrogate decision makers. I have done that, many times, because I have been taught to behave like that in a birthing room. And I feel there's no one who's a care provider who can, confidently stand up and say that I have never engaged in obstetric violence. What is just that's the beginning. You acknowledge that, and then you see, okay, what did we do wrong that we can change? It might not be intentional. It might be something that is embedded in our curriculum of midwifery, of nursing, of medicine, that you can't do anything about. But yes, when you talk about what obstetric violence is, it's very different for different countries. Some things are just plain and simple wrong and a violation of, women's fundamental human rights. When you talk about the physical violence, the verbal abuse, the sexual abuse, the lack of privacy. But some of the things we don't usually, it's so embedded in our culture, depending on how much violence women experience in their regular lives. Then she will, tell you whether that was violence, what she experienced while giving birth or not. If she's being hit, if she's being beaten up, if she's experiencing violence in her home environment every day, if she's used to it, that's a normalized thing for her. At least somebody's assisting, somebody qualified is assisting her birth. And that difference I noticed when I first presented my work at a normal labor and birth conference like 4 years ago, when I was talking about these extreme forms of violence, and I was hearing, evidence from other parts of the world where the extreme in those northern global north countries were more about the lack of consent. And I mean, nobody gets to have consent where I was, presenting from. So it's just, that basically is conditioning and your environment and your education and what drives birth and care and, people around it, and your own conditioning and how what you feel is wrong. So it's not trying to give a particular, definition of obstetric violence, because I've always strongly believed the person who gives birth gets to define what obstetric violence is for them and what respectful maternity care is for them, which is also something I am doing in my doctoral research with both women in one of the most populated and under resourced states in India called Bihar, and also going to nursing and midwifery leaders at all levels in different, like regulation, administration, advocacy, research, education, everything, to see how we can make changes in different these sectors to ensure respectful maternity care, because so much needs to happen to address obstetric violence and to ensure compassionate care.
I mean, that is quite a spectrum. I think a lot of midwives that are working in this country would be quite shocked about, the straightforward, as you describe, taking action again on women without their consent, but the shouting, the slapping, the pinching, the controlling, perhaps referring, in other countries a lot, they'll refer entirely to the husband or whoever has rights over the woman. But in many cases, as you say, there's a complete absence of consent or an absence of choice. And as you work your way into some parts of what you describe as the global north, your definition that, of course, if you look at it from the woman's point of view, if the professionals think that they're intervening to help, but the woman feels that violence is being performed on her, that sounds more like the dilemma that many midwives are wrestling with in the UK. And of course, there's always controversy about the levels of cesarean, etc. What kind of response do you get when you're talking to people in the global north about this? Do they think it's not a problem for them? Do they see the spectrum that you describe?
They do see the spectrum of abuse, and that is where I have also kind of felt that there is a spectrum, because I was completely coming from a Indian and Asian perspective, right? And so when I bring all the extreme experience, like extreme negative experience, and to give you an example, women, getting a postpartum IUCD inserted without their consent, and this is very, very, say healthcare facility specific. There is like a pattern of abuse that you see in particular places. So you'll see all the women in that surrounding, they will complain about, they have not been consented about getting a PPIUCD inserted. Or in another part of the world, you will see husband stitches very common. And every woman who's coming out of that place is, talking about that. So in terms of consent in the global north, then, I was seeing mostly about, injections or even palpation or even vaginal examination. But, those things, don't even think about asking women's consent. Women get vaginal examination, the care provider goes and just, lifts their, we call it petticoat or sari. They'll just lift it and they'll just say, checking, if they are in a mood to communicate. And sometimes they will just check it without saying anything. And this goes on with every woman. She experiences like numerous vaginal examinations by different people. And there is such a lack of communication between care providers that, nobody wants to check your documentation, and nobody documents. They'll all just come and, insert their fingers, and everybody wants to see. So those kind of things then help me understand the other side of the spectrum. As others I talk to in Global North are trying to learn these extreme examples, when I say, and people are moved to tears actually, most of the time, which kind of like it's like a pushback for me. And I wonder, like, why am I not crying? Am I losing compassion? These things are my routine life, these stories, everything. So yeah, it's quite a bit of an exchange.
We've had an extended year of the nurse and the midwife, and one of the big pushes has been around the pillars of regulation and education. And there has been some movement in India on adopting, more training and education, expansion of midwifery, a recognition that midwifery is the fastest route to reducing mortality and morbidity in childbirth. Are these issues being addressed either through the regulators or in the rather longer process that would be through education, or is that still far away from what you've seen in India?
I'm glad you asked that question. I think it's safe to begin by saying that regulation is really, really poor in my country when it comes to midwifery. And right now, midwifery is still embedded and within nursing. So it's not independent profession yet. So it's nursing council and state nursing councils which are regulating the professions in all the states at the national level. That is one kind of regulation. And the other is about, is there a law that women can approach and see what happens if they experience obstetric violence? While that is not something I have studied yet, and I wish to in future, I have done some research which recently got published on PLOS ONE about challenges in regulation. And it's one area which we do not usually talk about, because when it becomes act and a little bit of legal, we feel uncomfortable. And I think it's something about being women as well, that we do not want to get into those areas that we have not grown up speaking about. We are not comfortable about those areas. It's very poor. But then, having said that, talking about just the theory and practice mismatch, not having enough teachers, not having enough equipment, those kind of things are there. But I'm talking about absolute non-existent existence of midwifery council, midwifery profession, a definition of midwives, a scope of practice. But that is changing. A couple of years back, Government of India, we launched the operational guidelines for midwifery, and there is a lot of political will at the moment as well. But somewhere we keep getting off track. Like, what we are trying to call it is nurse practitioner in midwifery. So some way we are still not giving it its independence, status. And until that happens, I don't think it's, worth saying that we have made progress. And we want a direct entry midwifery. There is still a lot of pushback from that. What we are implementing at the moment is 18 months of this course that I mentioned. Yeah. But we have a bill, a nursing and midwifery draft bill, which is in the parliament at the moment. We all got to give feedback on that, and it's in a very poor shape.
Thanks for watching this video from the Maternity and Midwifery Forum. For more expert opinion and analysis, hit the button below to subscribe.